Hi, it's Roger Green. This week, all our posted conversations contain completed contents from our year-end interviews, edited only slightly for flow and background noise. This conversation is with our good friend Ken Cusi, who describes 2022 as, and I quote, the year it all came together, after a decade of work to elevate the issue of fatty liver disease beyond hepatology to a broader medical public and focus. Ken cites two major trends. First, publication and adoption of guidelines and clinical care pathways that increase requirements from screening in primary care and endocrinology settings. And second, promising phase 3 trials that suggest new NASH drugs are on a shorter-term horizon. Just a reminder, Surfing the NASH Tsunami will have next-day coverage of the two presentation days at NASH posting the Friday session around 6 p.m. Eastern U.S. Standard Time on Saturday, and the Saturday session around 6 p.m. Eastern Standard Time on Sunday. And here's Ken. So this morning, and it's morning for all of us except for Louise, we're here with Ken Cusi. Ken, how are you this morning?
Ken Cusi.
How are you, Roger? Great to be with you again.
Great to see you. Ken and I actually were on the phone yesterday talking about our other project, the Rising Tide Project, which I might throw a shameless plug for at some point. Louise, how are you today?
Louise Campbell.
I'm very well, thank you very much. Beautifully sunny and snowy here. This snow's not disappearing.
You know, I was talking with a friend in the Lake District yesterday who said that by comparison, you folks have it easy.
They're built for it. We're not.
He and his wife, who are British nationals, were in the southern U.S. for work for a few years and decided to change jobs and move back, could go anywhere, went to the Lake District, bought a 16th century small castle, and are dealing with the heating issues that affected everyone living in the 16th century. As I was talking with him yesterday, he was indoors wearing a down vest over a long sleeve sweater. And the other thing I guess I should mention is that Ken, for those who have heard him on the podcast before, may remember that he's Argentinian by birth and therefore has a strong rooting interest in Sunday's World Cup final. So Ken, how's the year winding up for you besides crazy?
Well, actually not. I took a couple of weeks of vacation in November around Thanksgiving and went to Argentina to visit family that I hadn't visited since COVID. So it was a good reunion and we had a big gathering. I went to the southern part of the country, which is beautiful, lots of lakes. So I've come refreshed to a lot of piled up work and very happy with Argentina. What can I say? Hopefully they'll do well in the World Cup, but it's just soccer, so let the best win.
You know, I think of you as an exceptionally generous and magnanimous person, but even by those standards, you just went way over the top on that one. I'm impressed. And Louise, how are you this morning? Now that I've spoken for you on the World Cup?
I'm very well, thank you very much. Supporting my fellow nurses out. Well, I'm not on strike personally, but I am supporting the industrial action, which is unprecedented for nurses to go out and strike in the UK.
So I'm happy we gave you something to do today that in no way, shape, or form affects the nursing strike in the UK. Jörn is on his way to Kolkata as we speak for his last trip of the year, so he couldn't be with us, but he sends his regards and warmest and dearest. Ken, as I think of the people that we're interviewing for the year-end episode and who had a monumental 2022, I think you're at or near the top of the list. Not mostly because not mostly because we piloted this podcast that's going to start in January and run monthly through 2023 and hopefully for years beyond, you and me, but actually because of some of the work that you've been doing around guidelines and pathways. Big year, huh?
Well, it's been a wonderful year. And again, the effort of many people in the field of NASH over years, we have tried to crystallize the effort of increasing awareness and a lot of effort of many people that participated in these guidelines. We were able to end 2022 with consistent guidelines that will help moving forward, prepare the field for the drugs that are under development, and also for highlighting the importance of early diagnosis. And we'll talk more about that. But I think it's like pushing a rock to the edge until you get it over. And I think finally a decade of work has come together. And I think 2023, with those tools, with the increasing awareness by a number of key organizations, and hopefully phase 3 trials that are very exciting and a lot of, to-be studies. I mean, I think finally we're making real objective progress.
Fantastic. So I want to go back in a second and talk about, as you said, early diagnosis and the idea that these guidelines are converging around the same topic. But just a question I'm curious about, what has been the magic? You said you've worked on this for a decade and this is the year it all came together. What made 2022 the magic year, or is it just serendipity?
Well, it's always a bit of both, but I believe the field expanded to true appreciation appreciation that this is a problem that needs to move out of the liver field to the trenches of non-hepatologists. That thought was always there, but really never materialized into real progress. I remember the guidelines we wrote a decade ago for AASLD, and then in 2018, there was hesitancy about, call it case finding in high-risk groups or screening, either way. And I think that has changed with the building evidence that people, particularly with type 2 diabetes and obesity, should be screened with some inexpensive tool. And I think that has turned into really a focus on going out of the liver field into the trenches, as I like to call it, to primary care, endocrinologists. That's going to make real difference. And again, I've been advocating. I remember I first wrote that we had to screen people with type 2 diabetes in the same way that we do people with diabetes for chronic kidney disease, for eye complications. And I hope I had some contribution in this evolution of thought, but there's now a broad consensus to do this.
A lot less lonely, huh? A lot more allies and colleagues for different places.
Yeah. Well, I heard that if you reach your dreams in your lifetime, you didn't dream big enough. But sometimes you see things happening, We just have to put in the homework, focus on what you think is important, and then it's not in your hands that things will turn out the way you want. Sometimes you get lucky and see the fruits of your labor, and others you don't. But this is the fruit, again, of many, many people. Louise has done a fantastic job where she is, each one of them adding to the greater good.
Now let's go back to the points of convergence, right? That we're talking about a common sense of screening and pushing out to frontline treaters, primary care, endocrinology. First of all, please, just for those who don't know, explain what's in the guidelines that addresses those sets of issues and how they fall out.
Yeah, I think one big step was the American Gastroenterological Association, AGA's 2021 effort that started in 2020 when Dr. Campbell came to me and a primary care doctor called Jay Shubbrook to put it together key opinion leaders, not only from the liver field that were still an important majority, but primary care, endocrinologists. I enrolled the American Diabetes Association, the Obesity Society, Endocrine Society, the American Association of Clinical Endocrinologists, and other relevant liver and primary. And then we came up with a framework that was published in 4 journals: the Obesity Society's journal, which is Obesity; Diabetes Care, which is the official journal, clinical journal of the American Diabetes Association; Gastroenterology, as you know, and Metabolism. And it was supposed to be a 2-day meeting. Then COVID made it complicated, so we did it virtually. But we came up with some common ideas and knowledge gaps. And the idea was how to identify with a low cost approach, because we don't have a lot of long-term cost effectiveness for more expensive tests. But the FIB4, which this group knows, or if others outside of liver field don't know, it's just an index that comes from age, liver enzymes, plasma aminotransferases, ALT, AST, and ALT, and platelets. And this gives you an index that, if it's high, can tell you that we need to do additional testing or you're at high risk of advanced liver fibrosis. So that simple tool, which is not fantastic, but it's a starting point, had 2 purposes. Develop a muscle for identifying people in these 3 high-risk groups: people with type 2 diabetes, people with obesity, particularly if they had risk factor, cardiometabolic risk factors, and people with elevated liver enzymes or steatosis by any incidental imaging. So 3 high-risk groups, a simple test, and then a second test, which in this case was imaging. And again, highlight the importance of multidisciplinary teams, a lot of the work Louise does. And then this was followed, I think, by another important guideline that started also in 2020, but materialized just 2 years later for a number of reasons: the American Association of Clinical Endocrinologists guideline that I accepted to co-chair with Dr. Isaacs from Atlanta, not to make another guideline, but just to develop more in depth what endocrinologists and primary care should do. So we, with the same framework and same guidelines, we just put more flesh on the bone and explained and addressed key issues. But the guidelines are basically the only difference. They added proprietary test called ELF that this liver audience, the hepatologists are very familiar with, to add in the case you didn't have FibroScan. And this is co-sponsored by the American Association for the Study of Liver Disease, particularly Dr. Iannuzzi and Dr. Rinella, Dr. Voss, because he also had a pediatric section. And I think this is also very important important, and we made it very simple. And then the AASLD, as you know, in the last meeting in November, updated their guidelines, and they're very well aligned with this. And I've been working with the American Diabetes Association that also in January are going to have a greatly expanded section on fatty liver disease, and we're going to be gathering very soon to spell out very clear recommendations that are going to be pretty aligned with this. So all these associations are now giving the same message and getting the field ready for action. And action, I have to say, the reason for screening is because we can do things today with nutritional counseling that induces weight loss, with bariatric surgery, and with some medications for obesity or diabetes like semaglutide in the very important study that was published in 2021, or pioglitazone from several studies.
So, you're preaching Louise's language, and by that I don't mean that we all speak different forms of English. I'm kind of talking about liver health and early screen and all that. Louise, why don't you take the next question? I have a couple of things I want to ask Ken about, but why don't you go ahead first?
I've left mainstream health to try and push this early awareness of liver, but actually for people to own their own liver health. Because actually, why at the moment the default is knowing about your liver when you've got disease, and actually knowing about your liver before you get disease, just when it's in a poor healthy state, is probably key for me. And I think Ken is absolutely correct in my book. If I just look at my recent experience in Australia, I only needed to scan 3 people to find fatty liver, but I only needed to screen 19 to find significant fibrosis. So where do we say that the numbers that we need to find stop screening being a positive tool when we look at fat in the liver being a poor health? Yes, some of them already had associated metabolic conditions, but I think Ken's comments on the FIB4, recently I think it was the Schmidt Heart Institute at Cedars-Sinai have just come out looking at FIB4 being when it was high, conferring a 4-fold increase in heart disease. So is the FIB4 may not be the best tool, but it's certainly getting some buy-in from cardiology, hepatology, endocrinology. Is that something that we can unify throughout the specialities, Ken? Is there that ability to unify on that?
I think so. And the beauty of FIB4 is that it is already in the electronic medical records of most of our doctors. They just don't know it. So education would allow people all over the world, I would say, to calculate this without going to the extra mile and begin then the conversation. Now, for the audience who's not very familiar with NAFLD and maybe listening, Louise mentioned an important aspect that having fat in the liver is a measure of your cardiometabolic health or unhealth, I would say. So the liver is like a mirror of how well you are doing metabolically, whether you're lean or obese. There are lean people or non-obese people that have fat in the liver. And if you look carefully, they're typically insulin resistant or have a family history of type 2 diabetes. We all have patients that have NASH and are not obese. So it's a good reflection of that. And what Louise mentioned is it's also a risk factor for cardiovascular disease. Now, we don't know if it's causative, but it's associated with cardiovascular disease. And this year in June, for the first time ever, the American Heart Association put together the evidence and highlighted to cardiologists how this is a risk factor for cardiovascular disease. So fat in the liver is a cardiometabolic risk factor for heart disease and for the development of diabetes. Now, the FIB4 focuses on the liver, but it can give you indirectly this additional cardiometabolic information. But from a liver perspective, what we want endocrinologists and primary care doctors is to get good at knowing what is the risk of that person for developing advanced fibrosis and cirrhosis. And by the way, we may also be preventing liver cancer to some extent. So a lot of things in that little test.
Well, actually, I think it's noteworthy that hepatocellular carcinoma is not only linked to cirrhosis, but also to advanced fibrosis as well, right? So you don't have to go all the way to fibrosis to be at risk for liver cancer. That's a good point. Ken, I was going to make a different comment, which is all 4 of those organizations that you mentioned start with the word American. And when you talk about electronic health records, I think what we in the States tend to forget, although it's come up in at least 3 of our conversations in this year-end round, and this is only the 4th or this is the 5th, is that Obamacare, whatever anybody in the U.S. thought of it, mandated pretty much much mandated and certainly get tremendous economic benefits, electronic health records. But when we talk to colleagues in Europe, for example, Jörn on an episode recently was talking about the challenges he has because all his results are still in paper, and he gets a patient and he's got to see what's in the paper file and then run over to the fax machine and see what came in, and there's that. And then, frankly, the U.S. may be the only country in the world that automatically puts AST and ALT in a blood panel.
Certainly, Michael Bettel made that comment.
Mike Patel made that comment about Canada. Jörn made that comment about Germany. In the States, for those two reasons, we are way far ahead of the rest of the world in terms of our ability to implement what you're talking about. A question becomes, where do you see leverage? A, what do you see in the rest of the world that maybe we're not? And B, where's the leverage to help those countries come along, and, where would you start? What would your advice be?
Well, that's a good question. And again, I just came from Argentina and actually trained in Argentina, and they include the liver enzymes in the routine chemistries, and a growing number of institutions have their data on electronic medical records, at least in Buenos Aires. So I know this would not be the case in smaller cities. So number one, we hope this with time will change. And before I forget, I mentioned the progress made in the United States, but I have to mention Latin American guidelines had included FIB4, European guidelines, Asian Pacific guidelines. So although I mentioned the progress we did, many other societies also gone in the same direction before or after. So it's not just an American lead. But how to fix that? I think once there's an awareness of the importance of what Louise said, liver health, liver enzymes are pretty and platelets, CBC, are fairly inexpensive. So if it's not ordered, I don't think that it would be a bad idea to order those liver tests and CBC once a year, which I think is being done. The only difference is if you don't have an electronic medical record, you're going to use a handheld, your phone, to do the calculation. It's hard to answer a worldwide question with so many healthcare systems, but I think, as you may suspect, the first thing is considering liver health priority or a right of every patient, and educating patients that they have to be proactive in taking care of their personal health.
You know what? So we wind up in the same place. The advice we've been giving on the podcast, Mike Patel and Global Liver and everybody else, is it should be a patient advocate priority everywhere in the world to make sure that those measures are taken regularly, particularly for patients who live with diabetes or obesity. Because as been pointed out, if you've got type 2 diabetes, if you live with type 2 diabetes, the question is less likely to be, do you have fatty liver? And the question is more likely to be, has it progressed?
Yeah, I wouldn't be that pessimistic, but they say a pessimist is an optimist well informed. So you might be right, Roger. What I think is that the key is education at all levels, to have strong democracies and to stay healthy, in the sense that if you have obesity, and I know it's many people, we all struggle with weight management, you have to then do the checks and work to see if there are complications. And if you have type 2 diabetes, it's going to be in your hands to go and see your doctor, check your eye checks, do your regular tests. So I think different organizations and different governments have to embrace the concept of care. Now, going back to our listeners, what the listeners can do is there are materials to educate the patient, the clinical care pathways developed, and these guidelines can be easily printed and put in their offices. There are patient health organizations with educational material, and I know, Roger, you've invited several of them over different podcasts. I think patient education will force the doctors to also, help the doctors remember the many, many things that they have to do in each visit.
Ken, do you think it also has to come down to education in medical school and in nursing colleges about the increasing knowledge about these risks? I'm very keen on you assess the person, not the individual diseases, because that just means somebody has multiple hospital appointments through different pathways for multiple parts of a disease process, yet they're the one person. And I know multimorbidity clinics are growing. Do you think that's where we need to be strengthening the education in medical school and all the way through, but also the use and the development of multimorbidity clinics?
Yeah, well, absolutely. So the two questions are, how do you train moving forward? And again, the multidisciplinary clinics. Definitely, when I studied, I remember very vividly that a line that said people with type 2 diabetes usually have fat in the liver. That is part of the disease. And it was a two-liner and no additional comment. I can remember all my career seeing people with fat in the liver and had no relevance. And I still see young doctors who, when they check out a patient we see in clinic, they see it first and I check it out and we discuss the case, that they have people with elevated liver enzyme. What is this? Oh, well, a transaminitis, a little bit of an elevation in liver enzymes. So there's a long way to go. So yes, we need to start early, but until it doesn't reach the cover of our magazines, that is going to take some time. But changes are happening. So I'm very excited. Yesterday, I get a primary care journal, and I was extremely excited that fatty liver was on the cover, and in the inside there was the AGA clinical care pathway figures. And I was very excited because I was telling my son that I have in pencil, I had written the draft of those with others, and then with Fasika we worked very hard, and then everybody made their comments. So I was so impressed that now it's in primary care. If you go back to other similar situations like screening for high cholesterol, or in the diabetes, screening with microalbuminuria to prevent chronic kidney disease, I remember primary care doctors listening and asking why, how. So it took a decade to make it happen. So I think we have a long decade ahead of education, but things are going pretty fast now. Back to multidisciplinary teams, yes, and this gets me sad because in the United States, it's very linked to insurance coverage and systems that have to be paid to deliver proper care, and many insurance companies are not vested in doing the best for people, but are driven by greed, I will have to say, and this does not facilitate multidisciplinary teams. But still, we are trying. So I don't know how it is in Australia. Is that any better?
I think most people will say it's bordering on the US system. It's partly Medicaid supported system. So if it's not Medicaid reciprocated, then you don't get it. FibroScan is only as part of the healthcare process, and you will only find it in a liver unit, which is one of the things we're trying to change, and with a particular focus in Western Australia. So therefore, I think Australia are leading the figures in liver cancer globally at the highest rate, but they have no figures on liver health. So I think we're a long way, and particularly if we only have to screen 1 in 3 people to find fatty liver. So there's work in the system, but I do agree with you on the American system. It's a lot more electronic record based. It would be relatively a simple leap to be able to scan and screen those records for FIB4s, for ALT raises, for those of common diseases where you could pick up high profile populations. So I think Australia has the potential to go from almost a third world in the way it looks at its liver health to being very much out there and being dynamic very quickly because of the size of the population and the systems that are in place. But will that happen? We don't know. I'd like to keep pushing and levering that, and hopefully with people doing that will be good. There's another aspect. We are looking at healthcare systems around the world collapsing with the amount of patients coming in and workforce shortfall. The one thing for me is to look at preventative care to stop these people coming into hospitals in the future. If we look at wellness rather than illness and look at liver health as that sort of elephant in the room that's never been looked at, the potential to reduce diabetes, heart disease, those related admissions actually looks to support healthcare, because we will never get enough nurses and doctors into the system at the rate population is growing. We don't devise, when we build big blocks of flats, we don't put a new hospital in, we reduce the beds. We do the opposite. We don't put schools in. So for me, being aware and being more preventative and looking at one of the big drivers of some of these diseases or reciprocants of some of those diseases, for me it's a healthcare saving as well as individual saving. We just need to harness the force, I suppose, of liver as our superhero and not see it as the villain in the piece most of the time.
Ken talked about it being the first snapshot of the first picture. Our friend Stephen Harrison, with whom Ken was in San Antonio many years ago before he came to Florida, talks about it being the canary in the coal mine, Stephen having a way with images. I think that's right. But then the question becomes, Louise, Ken, in a preventive context, what information do we need to give and who do we need to give it to so that people monitor themselves or the healthcare system enables people to monitor themselves early on when we're talking about liver health before we're talking about liver disease? How do we do that?
Well, for me, I think we harness the modern technologies that we do have. We can do a lot of have non-invasive tests. We can do the FIB4. The World Health Organization and most countries are targeting diabetes and heart health because they're plateauing. So if we just simply follow some of these new articles and evidence coming out and add the FIB4, that will automatically find an awful lot of our patients. But genuinely, I find people are very, very receptive to knowing about their liver health and how much they can change it. Once you describe the regenerative processes of liver and the surgical removal of 80% and it'll grow back in 4 to 6 weeks, people actually engage in how important this organ is for them. They forget that it's involved in the pathway for food and digestion until you talk to them about it, because everything's a heart diet or a diabetes diet. But to get the effect on diabetes and heart, you have to change the liver. So writing it into that discussion, I find, really engages people of any age, because you're never too old to change your liver health. You're never too old to stop giving your grandchildren sugar. There's always an opportunity. It's got to come back to giving people the opportunity to know their liver health, not just wait till they have liver disease. But that could be personally driven. There's an awful lot, a large rise in people paying for their own health screening. So I think it is awareness, but it's writing it into that dialogue.
And Ken, from where you sit, where do we go? How do we do that?
This is a big discussion, but the central concept is what Louise mentioned earlier, going in the mentality of public health from illness to wellness. And that's a very good concept. Again, policymakers have to be willing to invest in that, depending on how you view the world and your priorities. I mean, governments have to see as their top priorities the health care of their people and the education of their people. Unfortunately, that is not the priority, depending on your political views here and there. But again, I felt COVID would have been a moment of reflection of how important this is and to live in a different way. On a positive note for our listeners, I think that the younger generations are smarter, more ecologically aware. I was not aware of much of climate change when I was in my 20s. I was aware, but it was not that important to junk food. I mean, but I see a lot of youngsters now, my son and friends and others and nephews and nieces, that they are really very healthy. And I think it's going to be a generational change. Of course, we have to continue to educate, but I see that future generations will look at 50, 80 years from now, will look at us in a very primitive way. I mean, why would they eating all these cows and a lot of other things? So I think profound change takes time. Only revolutions change things overnight, but they don't tend to last. Sometimes they do. But I'm more of I think slow changes have a better chance of sticking around. And that's why I'm very optimistic, getting back to our listeners who want to hear about fatty liver, is that it seems that everything happened in the last 18 months, but this is just the culmination of long-standing, persistent efforts by a large group of people. Now, next is patient education, hopefully supported by organizations or public health efforts. Doctors doing the right thing, which most want to. They don't live in for any patients here, it's rough to be a doctor nowadays. I mean, there's a lot of pressures and demands, or any health or nurses or nurse practitioners. It's difficult for anybody in the healthcare system. We haven't had a break since COVID or before, and people are tired. But I'm very excited that the things are going in the right direction. And if the new drugs for NASH, many are not making it through, others will. And I think we will have in 3 or 4 years really a number of choices in addition to the current medications to treat diabetes and obesity to do this. So the outlook is great. And for those who have electronic medical records in the United States and are listening, for example, in Epic, you just have to put .fib4 and the number will appear in your notes.
On top of that, if you're working with LabCorp, they will reflex you an ELF if your FIB4 suggests that it's necessary.
Yeah, so I'm optimistic. This has been a great year for anybody who has fatty liver, in terms that their doctor will know what you're talking about if you go talk to them. Great for any non-hepatologists, because now they have a clear know-how and what to do. And for hepatologists, I think they should be happy. I'm not sure that they're going to get a lot more people to evaluate, but hopefully the first major breakthroughs to prevent cirrhosis at a larger scale.
First, an observation, and then two questions as we move towards wrapping this up. The observation is, I'm fascinated to hear a native of Argentina say in 50 years we're going to be asking, why are we eating all these cows? I think Argentina may be the last culture in the world that asked that question.
Yeah, you're absolutely right. We do a lot of nice things, but that's not at the top of our list.
Can just preserve the Malbec after you stop eating the cows, and I think we'll all be fine with that.
I agree.
I don't prioritize the cows. I do prioritize the Malbec personally.
I just agreed with everything you said because I was thinking Argentina, beef, well known for it.
Yeah, beef less expensive than chicken. Would you say that to people in the States, and they think that the Argentines must be out of their mind, but they just don't understand the environment?
Well, beef is very inexpensive in Argentina. It used to be very inexpensive and still is. So, or fish is a lot more expensive than the steak that in the supermarket costs $8 to $10. Over there is $1.
Yes, and frankly, it's really good beef too. I mean, if you eat beef, it's really good beef. So, first of all, what do you see happening in 2023? And then I want to take a look out 5 years. We haven't done this with anyone else we've done this interview with, but I think because the topics we're talking about are about significant change over time, I want to see if we can first talk about what do we see for 2023, and then if we had to take a crystal ball, what do we see for 2028 or 2030? Let's start with 2023. Ken, what do you see?
Well, I think we're going to consolidate the gains, and the unfinished work is to get large primary care organizations to develop or endorse the current guidelines. They participated, but have not been at the center stage. So I think that's an unfinished job. And to be honest, I see we will continue doing step-by-step progress in the clinical trials. Maybe there will be a new drug approved. And from the therapeutic perspective, I said we may have some approvals, but there's also, I have to tell, this is something that is not, people are not aware. There's a number of dual GLPs with glucagon or GIP that are in development. If you go to a diabetes meeting, there are like a dozen. So I think that field is going to be expanding and will be interesting to see at the ADA meeting in June. And I think that there's going to be a lot of publications trying to educate. The other aspect that I see in 2023 is there's going to be some consensus developed around the name of NAFLD or a umbrella terms. I'm not too excited personally with the change in name because I think it's coming at a time that we're taking off and it will create some confusion. But well, that effort has been championed by Dr. Newsom and Dr. Rinella with all the liver societies involved and involving also non-hepatologists and patients will come to fruition this year and hopefully will help remove some of the stigma of alcoholic or fatty, which is also controversial. We probably can discuss that at another time because the fatty term only applies to English and in any other language, it's not really. And again, many of my patients have never thought about it. So again, controversial, but it does, if it hurts a minority, maybe we still need to change that. But on more important things for curing this disease, I think now the rough work of getting the message out is what I see a lot happening in 2023.
So, Louise, I haven't asked you this question yet formally as part of any of our podcasts, but this one here, it seems apt. 2023, what do you see?
To be fair, certainly in the UK, an increased awareness of liver health. Ken, you may be aware that NICE have just closed the final public consultation on the guidelines, which they are going to, certainly on that last one, introduce FibroScan for access for all primary care physicians in the liver pathways, which is appropriate. So hopefully in hepatology, not only will we be finding more patients, we will get the right patients to hepatology to unblock the pathway of those with just soft fatty livers waiting on a FibroScan. But for me, it's what will happen to those soft fatty livers who have a normal stiffness range. How do we look and engage in primary care with that? For me, I'd like to see a lot more building of dietetics and resources in primary care because these are the people who will eventually end up on the pathway to some hospital admission, often cardiac, often type 2 diabetes, kidney failure. So we will be able to pick up and hopefully we will put a data system strong enough in place to capture that data throughout. That's with my rose-coloured spectacles on. What I have happen to feel, it may well be just piecemeal. We might put a machine here, we might put a machine there. We won't necessarily have a robust data frame, but we certainly have the ground to be able to do that and therefore find more fatty liver disease, look at reverse reversing some fibrosis and the opportunities. A lot of people may well be watching that in the future, because if we can get some robust data from that, and I'm sure Phil Newsom will be all over the data and the teams there from Litmus, so it will be great to potentially see that. But every time you do a FibroScan in the community setting or in primary care, you automatically increase education and awareness of the liver and how it interacts and and I think that's the strength of going out rather than sending people to primary care hubs or things like that. So that for me is my rose-coloured spectacles, because I agree with everything you've said on the medication side.
So here's my dare to dream moment. I don't know if this is 2023 or after, but one of the things that we've started to see is use of artificial intelligence and machine learning applied not just against biopsy, which is what you hear about a lot in this space, but applied against, in the States, medical records work out of Mayo Clinic about ways to use things like EKG, the predictive health intelligence experiment in Somerset with NHS, where they can go in and take a look there and apply AI. And the fact that it's in NHS, I think, matters in this regard. So I'm hoping that we'll get critical mass around the world at the idea that simple metabolic measures, FIB4 important, Ken, but not only FIB4, AI-based, can tell us a lot more about people's health than we've given it credit for. If we can do that, I think then it gets easier to get those tests done and to get those results to electronic systems. And then I think we can really start to make significant advances against liver health as well as against liver disease. I think the drugs will help, personally. I would like to think that 2023 is the year that we'll get an approval somewhere by the end of the year. I don't know that we're going to get there, but we hope we will. We have reasons to be optimistic. So that's my 2023. What's 2028, Ken?
Can I just ask a question on 2023, Ken? My understanding, and Hannes Hagström said it the other day, the diabetes databases in the countries are usually very, very good and very robust in their data collection and the numbers. Is there an opportunity to cross-reference the new diabetes guidelines, the heart guidelines and the AGA guidelines that you guys have worked so hard on, and implement it through those databases? Because obviously they're really high-risk populations. Is there a way or is that work being done?
Well, I would have, I may not be fully aware, but because the United States, the healthcare system is so fragmented and largely in the hands of half of private insurances and so forth, I'm not sure there's a national registry that where you can get all the people like you have in smaller European countries, or I don't know, maybe Israel or maybe Australia, but I'm not sure that. And again, also, I'm not sure what the aspects are of government going out to them, but maybe Medicare, Medicaid it can be, but it's also fragmented by states here. So this country has a very fragmented healthcare system. But going to your point, you could do that in a state, which would be like important. But I don't know, other than a Medicare, Medicaid, government, state by state approach, I don't think it can be done for healthcare issues here. And definitely if we take a long way, there'll be a long list of other priorities before fatty liver. So I know we're going late. In 5 years, what I think is going to happen, Roger, my dream is we're going to have version 2 or 3 of all these guidelines where we are going to be able to do better precision medicine, because the risk of people with diabetes for fibrosis and obesity is higher than if you just have diabetes without obesity, or if you just have obesity with diabetes and so forth. So we're going to now in 3 or 5 years say, hey, these are your highest risk people. You have to do this yearly, and the others much lower. So the guidelines are going to have a lot more precision. Hopefully FIB4 will be replaced with a better biomarker that will perform with great sensitivity and specificity. Imaging like a FibroScan will be more widely available, or a better test. And we will have a few drugs that are affordable to treat people. Like we think, for example, GLP-1s are great, but extremely expensive. And hopefully people will think that pioglitazone is a great drug if you don't have money, or to combine. We'll have combination trials with different drugs that work, and maybe some of those that are in phase 3 would have been approved. So I think in 5 years, you're going to be in a much better place all over, and doctors will routinely screen for fibrosis in people with high risk. So if I live, hopefully I'll be able to see that happen. And if not, I'll be proud that with Louise and you, we've done what we could to make it happen.
Using that as a transition, because we're at the top of the hour, I should mention that Ken and I are embarking on a new effort this year. We did 4 pilot episodes on this last year. It's called the NASH Tsunami and Diabetes, Getting Ahead of the Rising Tide. It will be a year-long monthly podcast for 2023 and hopefully years beyond. The series is sponsored by Novo Nordisk, but Novo Nordisk wants everybody, drug companies, diagnostics, everyone to know that they are encouraging companies, even companies who view themselves as competitors, to come in and sponsor an episode or to some other way to get involved in the educational activities that are going to be part of all this, since we all believe it's in everybody's interest to educate frontline treaters. We will be announcing at some point in the next couple of months that we're expanding creating a separate webpage for Rising Tide, and that webpage will provide other opportunities to reach out to treaters around the world and educate them. And Ken and I had a lot of fun doing this last year and got to share laughs with a lot of good friends and colleagues. And we're looking forward to more of the same starting in January with a conversation about what we're calling the Year of NASH. Louise, at some point during the year, we'll have to have you on to come talk about some of the work that you do and why liver health is so important in this context. And it's just one of these things we're going to be doing in 2023 besides the NASH Tsunami. So with that, Ken, let me let you go back to your day job. It's just for 7 minutes past the top of the hour. And Louise, I'll see you in 5 hours, right, for our next interview.
Roger, great to have you. Always fun. And all of you, if we don't talk before Christmas or the holidays, just wishing you the best.
We hope you have enjoyed this discussion. Please join us again later today for the full conversation between Louise, Roger, and their guest, Jeff Lazarus, here on the Surfing the NASH Tsunami podcast.